intraocular pressure actually helps in the reduction in slowing the progression of the disease. This brings about the concept of target intraocular pressure. Target intraocular pressure is a range of intraocular pressure that is a range of intraocular pressure where the progression of glaucoma or field loss among patients is reduced, or there is slowing or halting of the progression of visual field. It's a particular range, and it is an estimate that at that point, at that range of intraocular pressure, they noticed that the progression of the glaucoma is reduced. Target pressure as part of the treatment decision must be individualized according to the needs of the patient. I want to review certain clinical studies that has actually supported target intraocular pressure. We have they are actually randomized clinical trial. We have treatment versus non-treatment clinical study. This particular study tends to have two groups of patients, a group that were placed on treatment and a group that were left without treatment. And under this, we have the ocular hypertension treatment study. We have the early manifest clinical glaucoma trial. We have the collaborative normal tension glaucoma study. Then we have the treatment versus treatment clinical study, where there are two groups that were placed on treatment. Under this, we have the collaborative initial glaucoma treatment study and the advanced glaucoma intervention study. In ocular hypertension treatment study, 1,836 patients were enrolled into the study, and these patients had they had elevated intraocular pressure. However, there was no there was no there was no they had normal they had elevated intraocular pressure, but there was no findings of loss of visual field or damage to the optic nerve. And the objective of the study was to determine if early treatment and the use of topical ocular hypotensive medications can prevent the development of primary open angle glaucoma. And in the study, 20% initial, there was a reduction in the intraocular pressure of, there were two groups of patients, the patients that were placed on treatment and those that were not placed on treatment. Those that were placed on treatment, (20% initial intraocular high medications. When the outcome of the study showed that topical on. Hello.
Can I hear?
Okay, thank you, sir. The outcome of the study showed that topical medications, anti-glaucoma medications, actually reduced the incidence of primary open angle glaucoma, and the mean reduction of intraocular pressure in the treatment group was 22.5%. And it was also noticed that there was a decline in the progression of there was a decline in the progression of the disease in 4% of the treatment group over 6 months. However, in the control group, nine, sorry, in the treatment group, it was observed that 4% of them actually progressed to have the probability of developing primary open angle among the treatment group over 60 months was 4%, while for the control group, it was 9.5%. The early manifest glaucoma trial, there 225 patients with newly diagnosed open angle glaucoma were enrolled into the study, and the objective of the study was to compare the immediate effect of immediate therapy. The objective of the study was to see if early treatment for the if early treatment would benefit or lower the progression of the disease compared to late or no treatment in newly detected open angle glaucoma. That means that there were two groups. There was a group that was placed under treatment. As soon as they were diagnosed, they started treatment, while the other group, they were not placed under treatment immediately. They were either not placed on treatment or their treatment was started late. And also, part of the objectives was to determine the extent of intraocular pressure reduction attained by the treatment. The outcome of this study, in the control group, it took an average of 48 months to detect early signs of advancing disease against the treatment group, which took an average of 60 and 66 months longer to detect the early signs of the disease. A 25% decrease of intraocular pressure from baseline reduction reduced the risk of progression by 50%. That's part of their findings in the study. And also the risk of progression decreased 10% with each 1 millimeter mercury IOP reduction from the baseline. The collaborative normal tension and glaucoma study, there was 140 patients with progressing non-tension glaucoma. 28, there were two groups. A group that had 71 patients and a group that had 79 patients. The 71 patients were the treatment group, and among the 71, 28 of them had medical therapy, that is the use of eye drops, and with or without laser treatment, while the remaining 33 patients among the treatment group had surgical intervention, while in the remaining 79 patients were left without treatment. The objective of the study was the role of intraocular pressure control in preventing the progression of normal tension glaucoma. The study was designed such that intraocular pressure was lowered by 30% from the baseline within 6 months and maintained for 4 years by surgical or medical means. This was achieved among the treatment group. The outcome of the study showed that the treatment group showed a 12% rate of visual field impairment against the control group that showed 38% rate of progression. 30% or more lowering of intraocular pressure was noticed to slow the rate of visual loss, and the rate of progression among the control group was highly variable because there were other factors that was observed, like headaches, like migraine, the sex of the patients, like females, that contributed to a faster progression of the disease besides intraocular pressure. We have the collaborative initial glaucoma treatment study, which is a treatment versus treatment study. 607 patients with newly detected primary open angle glaucoma were enrolled in the study, and the objective of the study was to see if it was to compare treatment received by medications or eye drops against filtering surgery. And the study was designed such that target pressure was achieved by conservative therapy, followed by laser treatment or surgical treatment against surgical treatment. Actually, the patients were from the for this group of conservative therapy, some of them that did not do well in the for the conservative, the use of eye drops, they had laser treatment, and also depending on the outcome, they also added a surgical treatment, and while the other group had only surgical intervention. The outcome of the surgery of the study shows that the surgical intervention was more efficient in lowering the intraocular pressure compared to the use of eye drops, that is the conservative treatment, because they noticed that there was a decrease in intraocular pressure by 45% in the in those that received surgical intervention. And while in those that received conservative therapy, which is the use of eye medications, intraocular pressure was reduced by 38%. The, also, they found out that both interventions, the use of eye drops and also surgical intervention, actually were effective in bringing down the intraocular pressure. And there was also an importance of individualizing to when setting a target pressure in the management of glaucoma, it is good to individualize the treatment. In, ad, in advanced glaucoma intervention study, 591 patients were enrolled of two groups followed of there were two groups that were followed up for 5 years with advanced primary open angle glaucoma who were not doing well on high medication. The objective of the study was to determine if advanced medically uncontrolled open angle glaucoma is better treated by initial AGON by laser or by surgical intervention, that is trabeculectomy. The, the study was designed such that the first group received they received laser treatment. No, the first group received a laser treatment followed by a surgical treatment, which is trabeculectomy. Then the other group received the treatment in a reverse pattern. They were started with the surgical intervention, then laser, then surgical intervention. And these two groups were followed up for over 4 to 10 years. And their and their and the target pressure was set to be less than 18 millimeters in mercury. The outcome of the study showed that patients with lower intraocular pressure, that is mean of 12.3 millimeters mercury, were free from visual field impairment, whereas those with higher values of intraocular pressure sustained visual field deterioration. For most of this study, there were other findings in the study, but I actually just picked out the ones that concern that are relevant for my presentation. Now, the factors that determine the factors that determine target intraocular pressure and target pressure. When I want to set a target intraocular pressure, I will want to consider all this. First of all, in examining the patient, I want to know the extent of structural damage to the optic nerve, and this is done commonly when we check for the cup-Dix ratio. And from there, we can also we can also stage the disease condition as mild, moderate, and severe. Also, I want to um, check for the visual fields. I would like to, for the visual field, 2 visual field tests would be appropriate because you can, from the test, you can actually know the extent of damage of the disease. You can also know and compare the speed and rates of progression of the disease too. And this also serves as a baseline for subsequent visual field tests to monitor and also to see if if there is any progress in the treatment. The baseline intraocular pressure would also be taking notes. And the baseline intraocular pressure is actually the maximum um, pressure at which the damage is caused. And this pressure is taken not once. You want to take like three pressures of the patient at different times to know the baseline. Then also the age of the patient will determine. For example, a patient that is young with a mild disease condition and an elderly patient that has the same mild condition, disease condition, I will want to set a target pressure for the younger one. I want to be aggressive in the management of the younger one compared to the elderly one, which I'll also explain later as a result of the life expectancy. Then the corneal thickness of the patient, which I earlier said to know the thickness. The normal corneal thickness is supposed to be between 520 and 540 millimeters. Other factors I would like to take into consideration is the state of the fellow eye. If a patient presents with only one eye, while the fellow eye is already blind, I will want to be aggressive in my treatment in order to preserve vision in that only eye. Then the family history of blindness from glaucoma is very important because it tells us about the severity of the disease too. Then the ethnicity of the patient also tells us about the severity of the disease. Then in eye myopes too, the severity of the disease is also more in eye myopes. Then, like I said, the life expectancy of the patient. A patient that I know might not live for too long, like an elderly person that is maybe like 70 years, I will want to be more aggressive in a younger patient that have a longer life expectancy. Then vascular risk factors too will be considered as in, because there are also risk factors, and to control the intraocular pressure, it's also good to control other risk factors. So the method of determining target pressure, there are 3 methods that I got from the literature. We have the threshold or absolute cutoff value. We have the percentage reduction. Then we have the formula based method. The most often used by clinicians. And it is just like you want to set. Hello? Hello?
We can hear you.
Okay, thank you, Mark. A particular value is set. A particular value is set, and it's applied over a large number of patients that might have similar features. For So these values are set for both mild, moderate, and severe. For the mild, severe, 18 millimeters mercury is set. Then for the moderate, 15 millimeters mercury, and the severe, 12 millimeters mercury. Depending on the severity of the disease condition, you want to actually lower the pressure for as the severity increases. You want to lower the target intraocular pressure. Then percentage reduction method is the most simplest method, and it aims for percentage drop of intraocular pressure from the baseline in IOP. from the studies I discussed earlier, most of these studies they tend to use a percentage method to set a particular target severity of the disease condition, and a minimum percentage drop of 20% is acceptable. However, the percentage method is augmented with absolute value. They tend to combine the two together in clinical practice. So when we are combining the two together for the percentage and also for the absolute value, recommendations from AAO suggest that 20% reduction of untreated intraocular pressure, or an intraocular pressure of 17 to 18 millimeters for moderate disease, 30% reduction of untreated intraocular pressure, or an IOP of 14 to 16 millimeters mercury was recommended. Then for severe, 30% and 30 to 40% reduction of untreated intraocular pressure, or a fixed pressure of less than 12 millimeter mercury was recommended. Then the formula-based methods actually took into consideration the baseline intraocular pressure and other risk factors to arrive at target pressure. We have several formulas that has been there are several formulas. We have the Jampel formula, which um, took took into consideration, yes, the disease severity and also for the burden of the therapy. For this particular formula, there was an initial one and also a modified um, formula. And the target pressure is gotten from the product of the initial initial intraocular pressure. Okay, let me just read out the formula. We have the initial target intraocular. The initial target intraocular, we get the percentage of the initial target intraocular pressure, deduct it from 1, then multiply it by the initial intraocular pressure. Then we will now deduct it from the score, which we get. I the score, there are several scores for the modified um, for the modified formula. The score is from 0 to 5. Although I saw some literatures that are 0 to 7, but the one I picked out was 0 to 5. I also saw 0 to 3. And these scores actually they they tend to these scores are actually more like the classification of the disease. Right? For the one for 0 to 5, we have 0, which is for glaucoma suspect with low risk. Then we have 1 for glaucoma with high risk. Then we have 1, which is a mild disease. Then 2 for moderate disease. Then 3 for the severe disease. Then 4, I'm sorry, I can't really remember now, but maybe along the presentation I'll get back to it. Then the Y factor is actually the burden of the therapy, which was also scored as if the burden of therapy is mild on the patient, or is moderate on the patient, or is severe. There are scores attached to these numbers. Then we have the Zayens formula, which actually removed the burden of therapy from it. And the target pressure was gotten by the maximum intraocular pressure minus maximum intraocular pressure in percentage minus the Z score. Then we have the collaborative initial glaucoma treatment study formula, which is the target and pressure is gotten by We have a reference intraocular pressure plus the visual field score all over 100. All over 100, then we deduct 1 from whatever we get and multiply the outcome by the reference intraocular pressure. Now, in achieving the target intraocular pressure, like from the other studies, there is a medical treatment, surgical and laser treatment to achieve the target intraocular pressure, and it all depends on the physician, the ophthalmologist, and also the findings from the from when the patient is assessed, then you can determine which you would want to use. And the other factors too that would come into play in determining the particular treatment mode method. Then it was also said that reducing the intraocular pressure, either by lowering the intraocular pressure to the target point or by bringing down the intraocular pressure directly to the target point. And from the studies, there was a particular study that actually said that bringing down the target intraocular pressure, no, bringing down the intraocular pressure down directly to the target pressure is better than when it is done stepwise to achieve target pressure. I came across this schematic diagram in achieving target intraocular pressure based on the initial highest baseline intraocular pressure. And it's actually a um, medical treatment where eye medications are used to achieve the target intraocular pressure over a period of time. And it also allows for combination of eye drops to achieve the target intraocular pressure. And when this fails, we want to consider surgical intervention. There are also limitations to target pressure, in getting the target pressure, because in the process of trying to know the baseline intraocular pressure, there are variations in intraocular pressure over the day, and it's it has been noticed that the intraocular pressure is highest in the early mornings. Then also the corneal thickness of the patients would is also a limitation, because when we don't do the corneal thickness, we don't factor in the corneal thickness of the patient, it tends to affect our target pressure. Then adherence to the therapy. Some of these patients, some of the medications or treatments could be expensive for the patients to afford, and this would result in non-compliance. And actually, it would affect the target pressure, because once the patient is not compliant with his treatment, the target pressure would not be achieved. Then psychological impacts too. A patient, in setting the target intraocular pressure, it is done by the doctor and also the patient involved. The patient is aware of the target pressure, and in cases where in the next visit the patient comes and the pressure is not going down, they tend to be um, depressed, they tend to be sad, and this can actually result in non-compliance of therapy. In conclusion, determination of target pressure is an important step in the management of glaucoma, but it cannot be determined with any certainty, and achieving the set target pressure does not give complete assurance that disease progression will be prevented, as many other factors also play a part in glaucoma progression. So the adequacy of target pressure is reassessed periodically by comparing the optic nerve status with previous um, examinations. These are my references. Thank you very much.
All right. Dr. Oluwatosin, well done.
Thank you, sir.
That was fair enough. Dr. Oluwatosin is our youngest resident, so he has done fairly very well. So I will give room to people with question and comment. First, the resident, you can raise your hand or send in your question to the question and answer mode so that the presenter can attempt them. Thank you.